The idea behind this presentation is not to replace the pathologist, but I think as a pediatric oncologist, being aware of cytomorphology, of cytology, is important because usually the patients with AML-M3 or an infant with hyperleukocytosis or an M5 come in on a Friday afternoon or on a weekend, and I think most of you don't have a pathologist available at these times, and you have to make the diagnosis yourself. And learning cytomorphology was for me one of the most important things in my professional career, and that's it makes you independent, and that's why I also like it a lot. You all know, and I think this is very important, cytomorphology is not a standalone diagnostic tool. Yeah, I think you should always use this in combination with the patient's history, with the anamnesis, with his clinical presentation, and with the lab and imaging parameters, never as a standalone tool. And to make the correct diagnosis or a clue, it is very important that you get to learn the right technique to make a bone marrow smear or a peripheral blood smear. For example, at my institutions, all trainees who get a job at our institution must learn to do a peripheral blood or bone marrow smear themselves, because sometimes you don't have the people available who could do that, and to have to know about the proper technique and the staining is very important, because this will allow you to have a proper assessment of the cellular findings. You should also know what is a representative bone marrow. I think there are three aspects which are very important. You should be available. You should see the bone marrow fragments on the smears, and sometimes you can even see this macroscopically. You must find megakaryocytes within the bone marrow smear, and you must find the progenitor cells, so erythroid or myeloid progenitor cells. Only if these three aspects are fulfilled, you have a representative bone marrow. And this is, I think, what you have to check before you start judging a bone marrow. You can see a picture of a bone marrow. You can see the bone marrow fragments. When you go deeper, you can see the megakaryocytes, and you can also see the progenitor cells. Before coming to the quiz, because this is what's behind this presentation, I would like to guide you through a few principles that you should know about erythropoiesis, myelopoysis, and the other cells which are usually in the bone marrow. And I would like to start with erythropoiesis. These cells are usually round. The nucleus is also basically round, and in most cases centrally located. And in the context of the maturation of the erythroid cells, the cells become smaller, and the basophilic cytoplasm, which is initially present, becomes increasingly eosinophilic. What is very important, we usually don't see nucleic erythropoietic cells physiologically in the peripheral blood. If this is the case, there might be something wrong. For example, we have JMML as an example, where we not only see the monocytes, but also the erythroid progenitor cells in the peripheral blood. With regard to the nomenclature of the erythropoiesis, the youngest cell is the proerythroblast, followed by the basophilic, polychromatic, orthochromatic erythroblast, followed by the reticulocyte and the erythrocyte. I think this is something you know. Here you can see a picture of the proerythroblasts, and you can see this very deep blue cytoplasm, which is very typical. You see the round nuclei, and you see this so-called cytoplasmic pseudopodia, or what we sometimes say, these cytoplasmic ears. This is very, very, very typical. Here you can see orthochromatic erythroblasts. You see that the cells got smaller. Very importantly, you should not mistake this cell as an erythroid cell. This is a plasma cell, which has a very different looking. You can see that the nucleus is eccentric. We have this perinuclear lightening. and the cytoplasm, this is similar to the erythrocytes, is very deep blue. Now the principles for myelopoiesis. The youngest cell is the myeloblast. This is the only cell within the white cell lineage which has no granulation. Then very similar to the erythropoiesis, the cytoplasm in the younger cells is usually basophilic and coarsely granulated, and with the maturation process, the cytoplasm becomes increasingly eosinophilic and finally granulated. With regard to the cell nucleus, it is initially, when the cells are young, finely granulated. Later, the nucleus becomes condensed. Very importantly, it can help you to diagnose the cells correctly. We have a perinuclear lightening only in the promyelocytes and the myelocytes. And with regard to eosinophilic cells and basophilic cells, a principle that may help you to differentiate between them is that the eosinophilic granules never obscure the nucleus, while within the basophilic cells, the granules often even obscure the whole nucleus. The nomenclature, I think, is known by everyone. I don't have to go through it. Then a few words to the monocytes and lymphocytes. The monoblasts, which are the young cells, the youngest cells here, are usually very difficult to be differentiated from the myeloblasts. I will show you the pictures afterwards, but the cytoplasm can help you. Usually the cytoplasm of monocytes are pig and blue or gray, very uniform, and sometimes you see vacuoles. And very importantly, the nucleus is what we say very multifaceted. It can have very different pictures. Lymphocytes, I think, are known by everyone, very small cells with a condensed nucleus. We already talked about the plasma cells. So here you can see a cell in the bone marrow which has this blue cytoplasm, no granules. This is a myeloblast. The cell here is the largest cell within the white cell lineage. It's the promyelocyte with the blue cytoplasm, and here you can see the granules. Here you can see the promyelocyte and myelocyte beside each other. Here you can see the blue cytoplasm, the perinuclear lightening, very big cell, and here you can already see the next stage of differentiation. It's the myelocyte, again with the perinuclear lightening, but the cytoplasm is not that deep blue anymore. And here's another example of a myelocyte. Again, here the perinuclear lightening. The next stage of differentiation is the metamelocyte, which has lost this perinuclear lightening, and the cytoplasm is not blue anymore, more eosinophilic. And you can see the granules here. These are two examples for metamelocytes. Then the next stage is the banded granulocyte. This is known, I think, by most of you because you can see it in the peripheral blood, not only in the bone marrow, if patients have an infection. Then the Pelge-Houet anomaly. Who knows what it is? This is an inherited anomaly of the nucleus. Does it have a pathological relevance, or is it something which you can see but has no consequence for the patient? Yeah, it has no pathological relevance. It's a B-lobed nucleus, and it's a disruption of the maturation process of the nucleus, but it has no pathological relevance. The patients have a normal response to infections. Here you can see a toxic granulocyte, which is sometimes seen in peripheral blood when patients have a very, very severe infection with this increased number of granules. This is the promonocyte. Yeah? This is a very young cell, and you can see this uniform blue-gray cytoplasm, no granules, and you can see, and both of these cells are monocytes, that the nucleus might look completely differently. Here you can see a monoblast, and here again 2 examples of monocytes with very different outlook of the nucleus. So the last thing about theory, then we come to the quiz. Megakaryocytes, osteoblasts, and osteoclasts. The megakaryocytes are of course, the largest cells in the bone marrow. And usually they have a nucleus which is centrally located. And in the context of the maturation, the cells become increasingly larger, and the cytoplasm, again, initially basophilic, becomes increasingly eosinophilic. And with the maturation process, also the segments of the nucleus increase. The nomenclature is clear. Sometimes when you do a good bone marrow aspiration, you can also see osteoblasts and osteoclasts, which are described here, how they can be differentiated from each other. Here you can see the biggest cell in the bone marrow, namely the megakaryocytes. Here you can see the osteoblasts with this blue cytoplasm and this perinuclear lightening and the eccentric nucleus. And here you can see the osteoclasts with these multiple nuclei. Okay, now it's up to you to tell me what these cells are. We went through the theory. Perhaps some of you already knew about it. So what is this?
You're going to get turns if you don't.
I help you.
I have no clue.
I help you. It's a very small cell. Yeah. So, okay, I wanted to help her. Not to tell her the diagnosis.
I would guess an eosinophil.
No, it's a monocyte.
No.
Monocyte, promonocyte.
Yeah, that's good. Yeah, it's a lymphocyte, in fact, but this patient had an infection, so it's an activated lymphocyte, which may have a nucleus looking like a nucleus of a monocyte. So it's a monocytic lymphocyte. You're completely right. Great. What's this? A relatively big cell with a perinuclear lightening, but the cytoplasm is not deep blue.
You're allowed to help Fiona. Promyelocyte?
Pardon?
Promyelocyte?
It's a myelocyte. It's the next stage because it's the cytoplasm is not deep blue, but you were in the right cell lineage and nearly completely right. What's this? A small cell?
It's from the erythroid part, and erythroblast also.
Yes, correct. Great. It's a normal blast. What's this?
Granulocyte.
A what?
A banded granulocyte.
Yes, correct. That's good. What's this? We have seen this cell before.
It's yeah, I think so. Myelocyte something.
Yeah, it's already a banded.
Is it already a banded?
But you're right. It's in between the myelocyte and the banded granulocyte. Yeah, you're right. This is again, we can skip it. And what's this? What's this? It has no perinuclear lightening, but it's not like the cell.
Myelocyte?
Yeah, correct. Good. And a metamelocyte. Sorry, metamelocyte. Good. Next cell here, a very big cell, blue cytoplasm, perinuclear lightening.
I think that's a promyelocyte.
Yeah, that's correct. What's this? We have seen this cell.
Banded granulocyte.
Yeah, correct. What's this? Yeah.
Promyelocyte.
Yes, you have to learn because we need it. What's this? A very small cell, no cytoplasm, condensed nucleus.
A lymphocyte.
Yeah. Good. This is also again a lymphocyte. What's this? What would you say?
Promyelocyte.
Promyelocyte? I would say myelocyte. Why? Because the cytoplasm is not that deep blue anymore, but you still have the perinuclear lightening. So we could, of course, debate, but I would say it's a myelocyte. What's this? no perinuclear lightening.
Metamonocyte.
Yeah, correct. What's this?
Band
Yeah.
granules.
Good. This?
I have no clue at all.
Oh. Gray cytoplasm, very uniform. And the nucleus is not characteristic, but so it's
Monocyte?
yeah, correct, super. No, sorry, this was wrong. I would have also said, but it's a metamelocyte because you have the granules. This is my fault.
Three of us answer that, so.
Yeah. No. Good. When it comes now to malignant hemato-oncology, I would not go through all the details here, but you should be aware of malignancy criteria when you do cytomorphology. And many of these criteria are related to the nucleus. It's related to the nucleus size, especially to the nucleus-cytoplasm relation. This is something you should know. But for malignancy, we see often that a variability in the nucleus size. We see different outlook of the nuclei. We see mitosis. We see cells with multiple nuclei. I don't know whether, for example, it is the case in your institution, but we, until very recently, performed cytochemistry in all our leukemia cases. So we performed the periodic acid Schiff reaction to stain lipids, which are usually positive in ALL. We still perform acid phosphatase for the TLL cases, peroxidase for the myeloid leukemia, and esterase for the monocytic leukemias. In 1976, the so-called French-American-British classification, which still counts, had been established for acute leukemias, and for ALL, 3 subtypes are still differentiated, although it is not prognostic and also it is not used in the trials for anything, but we still classify by morphology and we still write down whether it's L1, L2, L3, and knowing L3 is very important, but I think most of you know why, and I will show a picture afterwards. Here you can see the L1 morphology, very easy. You have a homogeneous monomorphic population of small cells, no cytoplasm, no visible nucleoli. This is ALL L1, very easy. When you see it at diagnosis, it may be not so easy when you look at the bone marrow on day 15 or day 33 of induction, when only small amounts of leukemic cells are left. Then we come now to L2, completely different outlook. We have this non-homogeneous population of cells. We have cells with much more cytoplasm. We have cells with visible nucleoli. This is ALL. Both cases are ALL. And we know that TLLs are significantly more often with an L2 morphology than with an L1 morphology. And this explains what is written in the old books. When you look at in the old textbooks of oncology, it is written L2 morphology has a worse outcome than L1 morphology. This was due to the fact that TLLs were overrepresented in the L2 morphology as compared to L1, and in the former times TLL did worse. Nowadays, the prognosis is nearly the same. Here's L3 morphology. This is something you should all know because it's an emergency situation. When this patient comes in on the weekend, you cannot wait until Monday to make a diagnosis. And it is important to recognize this because L3 patients are treated completely differently than typical ALL. You have this blue cytoplasm, very typical, with these vacuoles. AML was always much more complicated because we had much more subtypes, you know, M0 until M7. Here you can see a distribution of these different subtypes. Of course, here it is written M3 only 5%, but you know that in Europe there is a difference between South Europe and the rest of Europe. In South European countries, you see much more patients with AML M3 than in the Middle European or North European countries. Here you can see M0. When you look at these cells, they are not so different from ALL L2. So the cytomorphological diagnosis of an AML M0 is very, very difficult. Of course, it's a very, very rare subtype, and it can, at the end, only be diagnosed by immunophenotyping, especially also by using peroxidase. But you can see the cells are very large, no granules, sometimes visible nucleoli, and not so different from L2. Then M1, you know, it's...
Wouldn't the size of the cells guide compared to L2?
Very difficult to answer the question. Of course, you are right that the myeloid leukemic cells are usually bigger than the lymphoid cells, but in L2 morphology, you may see patients who really have big blasts, much bigger than what we know from L1 morphology. So at the end, an M0 can never be diagnosed by morphology alone. You definitely need immunophenotyping.
Just a quick clinical question. If it's Friday afternoon and you don't get immunohistochemistry until Monday and you have a sick patient and want to start treatment, would you start ALL or AML treatment?
This is, of course, a very difficult question to answer because it depends on the clinical situation of the patient. If the patient is stable, there's no hyperleukocytosis, there is no clinical urgency, sometimes, as you know, we wait until Monday. But as M0 is very, very, very rare, and if I'm under pressure, I would start with corticosteroids. I would start with prednisone. I don't know, Martin or Carmelo, what would you do?
Yeah. I would say that in general, when you give a chemotherapy drug, it's a chemotherapy drug. Because sometimes you may also fail in the diagnosis. I mean, sometimes we have seen patients displaying some kind of infiltration, but eventually was not a leukemia. So it's better to start with steroids in general. I would say that this is safe for the patient and safe for you.
Sorry. Yes, AML M1, you know, myeloid leukemia without differentiation. This is, here you can see the blasts. You can see that they are bigger than the lymphoid leukemias. You can see the granules, which usually guide you through to the diagnosis of a myeloid leukemia. M2, myeloid leukemia with differentiation. You know that a significant number of these patients have the translocation 821. Here you should be really aware how normal cells of the white cell lineage look like, because you see this pathological differentiation in these leukemic patients, and you can see that the more mature cells look differently from the physiological counterparts. M3, this is an emergency, I think everyone knows, and we cannot wait for a pathologist on the weekend. You must make the diagnosis immediately, because if you don't make it, the patient can die from a life-threatening bleeding, from an intracranial hemorrhage. And for the classic M3, the diagnosis is not so difficult, because very typically you see this increased number of our rods in the cytoplasm, and what you also see are these cytoplasmic pseudopodia, and what is also typical, that the our rods and granules obscure the nucleus. So the classic M3 is not so difficult to be diagnosed, but it must be diagnosed, because you have to start immediately with treatment. And you know, it is defined by the translocation 1517. But we also have the M3 variant. And here you should be also aware of the fact that these leukemic cells have nuclei which are lobed, and these cells also have this cytoplasmic pseudopodia. M5. Is it an emergency situation or not if the patient comes with 70,000 leukocytes? Do we wait for the pathologist on Monday, or do we diagnose and treat? Yes, it can be it can be really a highly progressive disease with coagulation disturbances, with leukostasis problems, and so on and so forth. And the monoblastic leukemia is usually also not so difficult to be diagnosed because you have this blue cytoplasm, you have the vacuoles, and the cells are relatively big. M5b, this is the more mature monocytic leukemia. You can see again this typical lobed nuclei. You can see the blue-gray cytoplasm in these patients. Then we have a specific subtype of AML M4. It's AML M4-EO, which is characterized, as you know, by inversion 16. It's a very good prognostic marker, you know this, which leads to this fusion of MYH11 CBF-beta. And the morphology is characterized by this pathologically looking eosinophilic cells. M6, honestly, I've seen very, very rare cases of AML M6, this erythroid leukemia. You can see that these cells are not very, but they are similar to the physiological counterparts, the erythroid cells. You can see that the nuclei are round and the cytoplasm is blue. M7, this is very important also to know about because it typically occurs also in patients with constitutional trisomy 21. You have the cells with this very typical cytoplasmic pseudopodia. Here you can see them. Here you can see them. I will not go through JMML in detail. We have diagnostic criteria. You can look them up in every treatment protocol and textbook. But as I said before, the peripheral blood of JMML patients have two very typical findings. You have the monocytosis, and you see the erythroid progenitor cells in peripheral blood. Patients have a typical clinical presentation with hepatosplenomegaly, sometimes very critically ill patients. And then, before we come again to the quiz, the transient myeloproliferative disease in patients with constitutional trisomy 21. In these patients, we don't need a bone marrow. We never perform this. The diagnosis is made by peripheral blood. And here you can see the typical blasts, again, as with the M7, with the cytoplasmic pseudopodia. So, what is this?
L1.
ALL L1, correct? What is this? You see an increased number of our rods in the cytoplasm.
M3.
Pardon?
M3.
M3, correct? Good. What is this?
Cells.
Good. Normal or pathologic?
No, pathologic.
Pathologic. Good.
AML.
It's an
M5.
It's an AML-M5. Yeah, you can see the gray-blue cytoplasm, no granules, and the multifaceted nuclei. What's this? Non-homogeneous population of cells. Some are very small, some are bigger.
So still AML.
Myeloid leukemia or lymphoid leukemia? This is difficult. This shows you the limitations of morphology. Who said?
It can be a L2?
Yeah, correct. Yeah. At the end, it was an ALL case. Of course, this is. I could not make a photo of the whole bone marrow. But when you go through the bone marrow, of course, you see many of the small lymphoblasts, and then of course you see also the bigger ones. But there is a big number of lymphoblasts which are looking like the L1 subtype. So it's still there a population of small classic lymphoblasts. And I would treat this patient, of course, with corticosteroids and not think about an AML case. Good. What's this? Very, very rare. M. Okay, M is correct. 6 or 7, I heard both. Yes, this is an AML M6 case. What's this? A bone marrow. Is it pathologic or is it normal or is it something else? Yeah, this is a normal bone marrow. Yeah. Good. What's this? You have to recognize. Yeah. Very important. The term ALL has been abandoned. We don't say lymphoblastic leukemia to these cases anymore. This is either a mature B-cell leukemia or a mature acute B-cell leukemia or a Burkitt leukemia. The term lymphoblastic is not anymore used for these cases. This patient has a constitutional trisomy 21 and is a neonate, so what could this be?
TMD.
TMD, correct. Yeah. Okay, these are two different patients. But the cells look relatively similar. Yeah, we have big cells. We have some of the cells have a large amount of cytoplasm. You can see nucleoli. What does the patient have on the left side? What does the patient have on the right side?
Who has the microphone?
I don't know.
They're hiding.
I don't know what it is.
Okay, next one. This was a patient with really an AML M0. These are really cases. It's not that I'm writing something there. These are really cases because we make photographs of all our patients and we have a library of over 30 years with patients with leukemia. And this was an ALL-L2. So you see, it's not, we have limitations when we come to cytomorphology. Is this a bone marrow or could this be something else? Pardon? CSF, that's correct. Then we have, let's say, a myeloid leukemia, which has a tendency to have extramedullary manifestations. Which myeloid leukemia often has extramedullary manifestations? And look at the cells. I have explained to you these cells already. Yeah? Yeah. This was a patient with an AML M5. These are monoblasts. Often they have a KM2 or what we said before, MLL rearrangement. This is a peripheral blood. This patient came in with an increased serum creatinine, an increased uric acid, and the patient was thrombopenic, severely thrombopenic, and what?
Hemolytic uremic syndrome.
Yes, HUS. How did you recognize this? Only by the labs or by the morphology? What is this? Yes, these are fragmentocytes. So it was not a malignant disease. What's this? It's a bone marrow. It was a bone marrow with an increased number of cells in the bone marrow, but most of the cells looked normal, or almost all cells looked normal. The patient had hepatosplenomegaly and was an adolescent. What could this be? What?
Did the patient travel anywhere?
No. No. This is a pseudo-Gaucher cell. What could this be? Which malignant disease displays pseudo-Gaucher cells in the bone marrow? It's very rare. We have AML, ALL, and what do we still also have in pardon? No, the cells looked normal. There was no dysplasia. The adults even don't perform bone marrow punctures. CML. This was a CML patient. This patient, adolescent, a boy, he has a girlfriend since 2 weeks. and came in with lymphadenopathy and hepatosplenomegaly. What does this patient have? And what kind of cells are here? EBV, yeah, these are Pfeiffer cells, yeah. It's very important to recognize activated lymphocytes in virus infections, and they can even look like this, yeah, and activated or monocytic lymphocytes, right. Okay, what's this? Yeah, this is leishmaniasis and can cause really life-threatening HLH, yeah. These patients can be very ill, so it's rare. What's this? This patient has a immunodeficiency and a pathological appearance of his skin and eyes. Pardon? No. It has an albinism, the patient. Yeah, this is Heda Kigashi. You can see these pathological granules in the cells. Okay, this patient, we have learned this in the first module, had a lymph node resection. It was an adolescent, and here you can see a pathologic cell. Although the diagnosis in this case is made usually by histology, you can have a clue by cytomorphology. You can see a multinucleated cell here. You can see eosinophils, and usually the malignant cells.
Hodgkin's.
Yeah, this is Hodgkin's. That's correct. What's this? This patient was 2 years old, big tumor within the abdomen. We performed the bone marrow puncture. Yeah, they can be leukemic. So we don't need any biopsy, because if they are leukemic, we perform all the biological tests on the neuroblastoma cells. Okay, then we come now to the end. We have here, this is the last question to you. We have 4 patients. The first one has perhaps a little bit increased leukocytes. He's severely thrombopenic and also anemic. The second patient has decreased leukocytes, decreased hemoglobin, decreased thrombocytes. The third patient has a severe leukopenia and thrombopenia, and the fourth patient has an increased, severely increased number of leukocytes. Hemoglobin is a little bit lower than normal for his age. Thrombocytes are even increased. So, patient number 1, you remember, severely thrombopenic. Severely thrombopenic and anemic. What could this be? And these big cells here, whatever they are increased in the bone marrow. What is this a kind of cell? It's a megakaryocyte. So what this patient may have? Pardon? No? No. Severely thrombopenic. ITP, yeah. Because it's bleeding. Okay, that was the clue with this case. Second patient, I think this is easy. This is ALL. Now the third patient, I told you, all cell lineages were severely decreased. And then we performed the bone marrow puncture and see this bone marrow with a decreased number of cells. What this patient may have? Yeah. Good. And the fourth patient, I told you 60,000 leukocytes. Thrombocytes, let's say normal. It's an infection. Okay, that's all from my side. This was cytomorphology. Okay, now or there are questions, but I think you had to answer my questions. If not,
I just want to get back.
But there's one question from behind.
Okay.
Thank you for the presentation. Okay, it's working. I have a question regarding the situation in which you have patients who are coming in on Friday evening, and you have the cytomorphology with the diagnosis of an ALL or an AML. What do you do with the genetic testing and with all the immunophenotyping? What do you do with the blood test? Do you perform another bone marrow puncture on Monday, or? Because you can influence the test results afterwards if the treatment is working.
I think it depends on what are the resources in your hospital. We have the possibility, if the patient comes in on Friday, to perform the bone marrow puncture, the lumbar puncture, and the first intrathecal on Saturday. So I want to have the diagnosis on Friday because I want to prepare the parents, I want to talk with them, and I wanted to make the diagnosis myself, not to lose the weekend. And we usually perform everything on Saturday, on Sunday. If we don't have the possibility, we postpone the bone marrow puncture also to Monday, but don't start the treatment if the patient is not under danger. Nothing will happen if you wait in an ALL patient 24 or 48 hours. If there's no hoop hyperleukocytosis, if there's no mediastinal tumor, if there's no tumor lysis.
We do not have the possibility on Friday to call in the genetical testing.
It depends on your patient, and what you should not forget, if there are enough leukemic cells in the peripheral blood, you can take the blood and make every genetic diagnosis from peripheral blood, and you don't need bone marrow.
But do you have the possibility, or do we have the possibility to store the blood?
Of course. Nothing, you can leave it outside at room temperature, nothing will happen.
And for how long would you recommend?
We have the possibility to do everything also with the management of the samples on Saturday, but we don't have it for Sunday, so we leave it at room temperature, and on Monday morning, send it to the lab.
Thank you.
But it really depends on your resources and on the clinical situation of the patient. In many cases, you are not under pressure. And especially within the IOPFM protocol, we have the problem, or not the problem, we have the situation that day 15 is stratifying. So we usually want to have day 1 on a Monday, or not on a Saturday or a Sunday, because then day 15 is also on Saturday and Sunday. So we postpone until Monday. But if the patient is under danger, I don't care about weekends.
Okay,
you
should not care about weekends.
So you specifically have flow cytometry on Saturday but not Sunday?
No.
How do you make the diagnosis of ALL?
ALL, we usually diagnose by morphology.
Morphology only?
We never wait for immunophenotyping.
Oh.
We can also not perform immunophenotyping on Saturday and Sunday. Have to wait until Monday. But that's why I'm teaching cytomorphology, because I don't want to be independent or dependent on a fax analysis on a Friday, Saturday, and Sunday if I have a critically ill patient. And we also, to be honest, I don't know how it's done by Carmelo or Martin in your centers, we even don't wait for the immunophenotyping if I'm morphologically sure on a Tuesday that this is ALL, I inject the first methotrexate. I don't wait that someone looks at the bone marrow and then tells me this is ALL, and then I do another anesthesia to inject methotrexate. So if I'm morphologically sure, I inject the first methotrexate. Carmelo?
Well, first of all, I think that it's better to wait, as Andisha said, if you are not under pressure, don't do anything. It's better not to do anything than doing something wrong, because you are not under pressure. The patient is probably fine. Maybe it's anemic. Sometimes can be slightly or mildly thrombocytopenic, but you don't need to rush towards a treatment. Then there are some places where you may have the expertise of having a morphological evaluation. Some centers you may have also the immunocytofluorimetry. In general, I think that the situation is in the small, medium-sized centers, you start the treatment only if you are in trouble. And for the matter of centralizing or taking the blood or the sample, we usually centralize the samples, and these samples go over the country for at least 48 hours. So nothing happens. So you may have the diagnosis also 2 days later with the same sample.
I think one more and last question then.
Sorry, I'm very interested about where do you have your microscope? Is it like, and it depends as well on where do you perform the lumbar puncture and the bone marrow aspiration, because this is very different from centers to centers. For us, we do everything under anesthesia,
yes,
which is not always the best solution, I guess. But where do you do that? If you are like in the anesthesia room, so do you have like at hand that you have your lumbar puncture ready and that you have your microscope next to you?
Yeah.
Do you wait for the sample to be sent to the morphological analysis? For us, this is more of a question. Like,
this is, of course, different from center to center. I can speak for our center and also some other centers. We perform, of course, everything in general anesthesia, but we don't go for a lumbar or bone marrow puncture in anesthesia into an operation room. We do it on the ward. We have always an anesthesiologist available on the weekends and also during the night shift, so this is not a problem for us. And the microscope is in our general lab. So I do the smears myself or with a colleague. I for example, the bone marrow puncture and a colleague is making the smears. Then we go to the lab, we do the staining ourselves. It takes 45 minutes, and then I look into the microscope and have the diagnosis. Of course, this is not something which occurs very frequently, but we can manage this, and we are not. An ALL is very easily diagnosed. I don't need immunophenotyping on the weekend. So we have everything available also during the night or on the weekends. But as Carmelo said, if you don't have these resources available, wait unless the patient is in a clinically life-threatening situation. With an AMLM3, you cannot wait until Monday. When you look at the old papers, AMLM3 had a very, very poor prognosis because they died of intracranial hemorrhage. Now it's the best prognostic subgroup because we know how to treat it, but you have to recognize it, also on a Friday evening or on a Saturday.
I think we should use Oscar here, according to Madalena's question, because geneticists are not always happy with the samples for under room temperature for 48 hours. Any comment?
No.
But in principle, that has to be because we are a centralized lab and we receive samples from all Austria. So they're on the way at least 24 hours to 48 hours. Yeah. And that's, in winter it's a problem because then it's frozen. And in summer it can get 30, 40 degrees, but room temperature is always fine.